So in this second sessions, this is the first sessions, but in the second speaker, after we talked about water, and now we talked about air, air. In the first speaker, we talked about water, it was water, and then water contamination, etc. And now we talked about the air pollutions that will affect on our health, environment. And this is also very important for us here in Indonesia. The pollution is still the major cause of health problem. It's like in the first sessions water and now air. It's like avatar, avatar. Avatar. So One Health, that's why One Health is a very multidisciplinary. So from anthropologists, where is from anthropologists, biologists, medical doctor, etc. We come and work together, to tackle or to handle the health problems around the world. Not only health, but the environmental. Now we will invite the second speaker, Prof. Chuang Hsiao. Prof. Hsiao, it's our great honor, to introduce Prof. Chuang Hsiao from Taipei Medical University, Taiwan, So Prof. Chuang is also my teacher, when I was studied in my PhD program in Taipei Medical University, Taiwan. So I know him. Prof. Chuang is is a distinguished researcher in environmental health, whose work has significantly advanced our understanding of how environmental pollutants affect human health. Maybe I will introduce briefly. Prof. Chuang is a full professor at the School of Respiratory Therapy, College of Medicine, Taipei Medical University, Taiwan. He currently serves as a president of Taiwan Society for Aerosols in Medicine and is also a visiting professor at Imperial College London, United Kingdom. And his research focuses on inhalation toxicology, aerosol therapeutics, and environmental lung diseases. And he leads the inhalation toxicology. Given his extensive expertise in environmental health and pollution-related disease, we are honored to have him with us today. And he will present pollution-related disease in environmental health risk. Prof. Chuang, the floor is yours. Take a pause.
Selamat pagi. Selamat pagi. Okay, and first of all, I would say thank you for having me today. I'm really honored to be here for presenting my study. And just want to mention about Dr. Daniel. I quite enjoy his talk and talking about the water because I'm also doing like a microplastic. Thank you. So from water, I'm going to talk about air. So and today I'm talking about air pollution or pollution-related disease and environmental health risk. I'm Hsiao from Taipei Medical University. So the aims for talk today, I'm talking about the associations between air pollution and the COPD pathogenesis. COPD is for chronic obstructive pulmonary disease, which is very important pulmonary disease nowadays. And I'm trying to identify, is there any air pollution associated COPD phenotyping? And in the end, I'll go further to talking about mechanisms. Is there any underlying mechanisms that are related to COPD caused by air pollution exposure? So that's 3 M's for today's talk. So first of all, I will start from air pollution. Air pollution is very important public health issues nowadays because they will be affected about 92% of the people worldwide being kind of suffered by different levels of air pollution. And it's not only the situation or public health concerns in a developing country, also an important public health issues in developed countries such as the US, Europe, or Japan, and so on. So here is the pictures. We can see that a lot of traffic emissions. This is a picture taken from Vietnam. And the first time I visited Vietnam about 6 years ago, it's very surprised me because there's kind of massive a lot of scooters mixing with the cars. But that means the people are really living without air pollution. And the same situations, we can see that a lot of people, they use biomass burning for cooking, as Professor Daniel just mentioned. So burning for cooking or burning for heating is very common for some countries or some areas. And if you like a barbecuing, it's still kind of like exposure to air pollutions. So in fact, the situations in Indonesia, you can see the pictures in here. So the government in Indonesia, they want to put more notice and more efforts on air pollution. However, there's no people can really avoid to air pollution exposure because there's news talking about all ages are suffer and being affected by air pollution based on the data in Indonesia. And here is the island for Indonesia, and we can see there's different major sources emitted from for air pollution. The major one depends on the cities, of course, but if we're looking at deeper, we can see like the biomass burning and traffic emissions are very common emission sources between the cities. So how we can really dealing with this kind of pollutants is a very good issues nowadays, how we can really facing it and how we can prevent it. So that's a strategy that we need to know. So air quality and air pollution is very important like economic burden. So here's some countries like from India, Delhi, Mexico, and like from China, Shanghai, Japan, and Jakarta, Indonesia. You can see that about 13,000 people could be caused by premature death. And that'll be about 3.4 billion of like economic causes by the US dollars. So that means like a lot of disease that are really related to the air pollution exposure. However, how we can really understand it? So first of all, I want to talk about what is air pollution. Air pollution is including like a gas phase, solid phase, such as a dust or like a film, odor, bad smells. Is kind of like a definition for air pollution. And it's not only effect on humans, it's effect on animals, plants, and so on. And it's different medium, such as air pollution could also contaminate water, like Daniel just mentioned. So different contamination. And the air pollution could contaminate the vegetable, the plant, that would be being taken by ourselves. So that's different rule for air pollution exposure nowadays. Where should I point? This way? This way. Oh, okay. So the first air pollution event is being identified in 1952 in London because the industrial revolutions, people need to using burning the coal and to produce a steam. Then there the machine really working. So most of these companies or manufacturers should be built nearby the river, Thames River. And during the winter conditions, the emissions or dispersions of pollutants are quite weak. So a lot of pollutant accumulated during that days. So in a week of time in London in 1952, that caused about 4,300 deaths during a couple of days in London in the winter time. So the scientists or the epidemiologists want to understand what happened. However, at that time, there's no advanced statistical approaches. So the basic way we can see by trend. So we are using like a different disease that being, kind of like increased, and we can see the trend is caused by air pollution as well. So we can see when air pollution increase, it also cause like a death by pneumonia, bronchiolitis, tuberculosis, and heart failure. So from the knowledge on that date, we can see air pollution could cause like a cardiopulmonary disease and infections as well. And about 50, 60 years after, there are lots of resources from the US or from the Europe. They really want to understand what happened between air pollution and our health. So they using different type of like a cohort to build out the knowledge provided for the decision making. So this is paper published in Circulation. They identify when air pollution really increase like cardiopulmonary mortality. So we can see like chronic pulmonary disease or like cardiovascular disease and so on. This kind of disease being increases the risk by air pollution. So that gives us more confidence, evidence that air pollution is really causing our health damage. But in clinics, the seasonal disease is commonly used to describe it. So when patients come to the clinics or go to the hospital, and the doctor will say because the seasonal changes, so that's why you are admit to the hospital. However, if we're looking at deeper, we can see by different seasons, and like COPD or like respiratory infections, tuberculosis, bronchitis being increased or being changed by the season. Of course, same as asthma. But if we're looking at the difference, we can see the COPD is significantly being changed by the season. So is that really due to the seasons and how we define the seasons and what happened by different seasons? That would be the key issues that we need to understand. So I'm talking about a little bit COPD. So COPD, chronic obstructive pulmonary disease, which is being recognized as an important public health issues nowadays. It's not only the public health issues in like a developed country and also in like a developing countries. However, it really depends on the diagnosis rate. So based on the report, it mentioned about 384 million people being suffered by the COPD, and it caused about like 3 million people death due to the COPD. And it's the third leading cause by COPD worldwide. And there are lots of risk factors. First one, we know like a smoking behavior is a major risk factor for COPD development. And then next one is like indoor-outdoor air pollution. And the third one is occupational dust exposure. So that means the smoking, air pollution from indoor-outdoor, and the occupational exposure are the major causes that leading to the COPD development. However, if we identifying the COPD by different experimental design, so there'll be two different designs, such as like if we do like a retrospective study. So that means we collect COPD patients and we see how the historical smoking behavior, and we can identify the association about 80% of like a COPD patient. They had the smoking history. So remember, 80% from the patient. But if we do like a prospective study, that means we collect a healthy subject and following a period of time, which calls like a cohort study, then that will be about 40 to 50% of the smokers that will develop to COPD. So we can see the difference by its different experiment design. If we collect a patient to see the smoking history, that'll be 80%. But if we collect the healthy subject and do a long-term follow-up, that'll be only 40% to 50%. So that'll be around the 30% difference. So what happened and what's the difference? So based on the Lancet report, they mentioned about globally, about 55% of COPD subjects, they don't have the smoking history. So that means beyond the smoking, there would be the other factors that really affected on our lungs. So what's the factors? First one is the air pollution from indoor-outdoor. Normally, we burning biomasses for the cooking. That will be the major exposure, probably from the indoor. And the traffic emissions that we pose probably from like outdoor air pollution, or there's some industries emissions that causing our outdoor air pollution as well. And the other one factor is asthma. Then there'll be occupational exposure, such as like minings or like weldings, this kind of disease that caused by occupational exposure. And then like infections or like the other types of like lung development due to pregnancies and so on, like different factors. Of course, aging is a major factor for COPD. So based on the GO guideline, which is the standard guideline for diagnosis COPD, they try to identify is there any etiologies for COPD. So they distinguish and classify it by COPD-G, G is for gym, and such as like alpha-1 antitrypsin deficiency. And the other one is COPD-D. So it's due to abnormal development, such as like when a woman's during the pregnancy, they still do the smoking, or they still do some like walking, but however, exposed to high levels of like dust or air pollutions, or they are exposed to relative higher air pollution level already. So kind of like affect their like baby development and leading to like immature or premature lung development during the pregnancy period. And the other one is we call it COPD-C. So it's very interesting. From the GO guideline, they try to distinguish the difference between like smoking and the air pollutions, because the scientists realized that there could be some difference. Of course, the exposure are different, but the phenotyping or the etiologies could be different by the smoking behavior for COPD-C and the COPD-P. P is for like pollutions. So if like COPD not really related to air pollutions or like biomass burning, so we can call it ET top for like COPD-P. And the other one is COPD-I. So it's for like infections. Then COPD-A, it's kind of overlapping between asthma and COPD. A portion of asthma patients, they will develop into COPD in the end. So it's kind of like overlapping. And the other one is the unknown factor. There's still a portions, small portions of COPD that's still unknown. So the first evidence that being identified by epidemiologists due to air pollution is like a lung function decline in the lung. So this is study that identified the air pollution exposure such as like PM 2.5. PM is stand for particulate matter, 2.5 is for the particle size fractions. So 2.5 means like a 2.5 micrometer in air diameter. So if we say it's PM10, which means like a 10 micrometer in the air diameter. So PM 2.5 and nitrous dioxide are the major sources. And nitrous dioxide is for like traffic emissions. So we can see that the subject who is exposed to air pollution could lead into like lung function decline by FVC decrease and like FVC delta decrease and so on. But if we're looking at the degree of a decrease, we can identify that like healthy subjects, they are more vulnerable to air pollution exposure by lung function decline when compared with the COPD. But as our knowledge, we think about the COPD could be more sensitive to air pollution. But what happened? Because COPD is irreversible lung disease. So that means when the lung function declined, the lung function cannot really be reserved or reversed by the medical treatment. However, for the healthy subject, the lung function still can be reserved. So they have more like a degree that can be changed. So in terms of like a COPD, there are two types that are commonly being identified. One is bronchiolitis, the other one is emphysema. Bronchiolitis means like after continuous stimulations by like oxidative stress or like by the inflammation, the airway wall will be getting thickness, and that will be increasing or reducing the lung functions. And the other one is emphysema. Emphysema means like alveolar, the wall, just like a honeycomb, but it's kind of being destroyed. So that means the more air being held into a lung, distal lung, but the air cannot really be exhaled. So it's kind of leading to air trapping in the lung in COPD patients. So what types of like phenotypings of a COPD, bronchiolitis or emphysema is really related to air pollution or both of them? That raises a question to the scientist. So first of all, in our group, we start a cohort study and we try to understanding occupational dust exposure, which means like a mental field exposure. Is that really can leading to like a COPD development or causing like a lung function decline? So based on like epidemiology decide, and if we can select a occupational cohort, that will be much easier for us by like to get evidence from the general cohort study, because for the occupation cohort, it's more clear for the cost and the outcome. So it's easier to identify the causal relationship because this kind of subject, they are mainly exposed to certain type of risk under the working environment. So in our work, we have done about 10 years follow-up from the shipyard worker in Taiwan. And now we collect the data for 4 years to see how about like a COPD development from a healthy worker to like a COPD. And surprisingly, we can identify around the 2.5 overall incidence rate in the workers. And the workers are mainly exposed like a welding film. But based on the OSA, they're talking about a welding film is kind of like a fever-like symptom, not only causing like a short-term breathlessness or like leading to the short-term uncomfortable like illness and so on. So based on occupational definitions, they don't think the welding film exposure is really an important occupational health concern. But based on the study, we identify after long-term exposure to like welding film, now leading to the COPD development. And especially we can see the non-smoker have higher incidence rate when compared with like a non-smoker. That's very interesting. So supposedly non-smokers, they probably have like a more lung function that can be really declined by like a welding film because smokers, there has been kind of like lung function being destroyed by smoking behaviors already. And of course, the welders, they have higher risk by incidence rate when compared with the office worker. And interesting in this one, the personal protective mask is like a welding mask. It's already help to protect workers' health, especially in the lung respiratory system. So based on results, if the worker wears, doesn't matter they wear the mask or not, we still can see the incidence rate are quite equally. So what happened? Because during the welding, it's really hot, humid. So properly welding the mask is very important. So it's more like a behavior science or like social science, how we can teach, educate workers and to make sure they're wearing the mask properly. That's a key issue. It's not only for like occupational health, it's also for their personal health as well. But in the end, we can see after occupational exposure, the lung function did of dust declined by welding exposure. So that gives us an evidence that air pollution is really associated with like a COPD development. And as I just mentioned, bronchiolitis or emphysema, which type is really associated with like air pollution. And this is a report published by JAMA. They use 2 type experiment design. It's very interesting. And now they more and more like a good rank journal. They use 2 experiment design to get evidence. So first of all is a cross-sectional experiment design, which means at the point when the subject being recruited into our study. So it's a baseline. So based on baseline, they can do the retrospective air pollution exposure by different years based on the like residential addresses. So based on the study, they identify different types of air pollution, including a gas pollutant, ozone, or particulate matter, PM2.5. They are also associated with like emphysema risk. But when this cohort being followed up for 10 years, we can see the risk for the emphysema progression only can be identified in the gas pollutants only. So is that real? How about the particulate matters? Because the particulate matters has been recognized as an important public health issues in terms of like air pollution exposure as well. So we try to confirm the report, the evidences from the JAMA study. So we conduct a meta-analysis study, and based on study, not surprised, we still can see the gas pollutants such as ozone is really associated with the emphysema. So that's the things. Gas pollutants is associated with like COPD, and it may be associated with emphysema development. And in fact, for the animal model, if you want to induce emphysema animal model, put the mice exposed to ozone is one of the model to induce emphysema. So that makes sense. But how about particulate matter? So we try to identify what happened. Is there any like subgroupings, mistake, and can we get a really precisely associations that between air pollution, particulate matters, and emphysema? So we collect around hundreds of subjects in hospital and collect like the CT scan, and based on CT scan, they can identify which type of emphysema that really belong to in COPD subject. And we use different types of emphysema, such as like parastole or centrolobular or like paralobular, different kind of like emphysema type, and try to associate it with particulate matter. And based on the particulate matter exposure, we using the particle deposition model because different patients, they have a different lung function that will be affect the particle deposition after inhalations. So we personalizes the deposition rate by the air pollutions, so we can do further association between air pollutions with like a different emphysema lobe. So we still can see the association between gas pollutant. However, we can identify most of like a risk with a higher risk being can be identified in like a lower in lower lobe emphysema. So let us raising a questions, because we have identified associations in the subject. But for me, I'm doing like inhalation toxicology. So animal to prove the concept is much more important because we get the associations from epidemiologists. Of course, we can get association by cohort study. We can identify the causal relationship. However, if we can using the animal, it's much easier to looking at your X and the Y. Y means like an outcome. So we build out a real world exposure system. Why we use this system? Because traditionally, if we want to look at inhalation toxicology, we prepare the particle suspended in like PBS, and we use a microspray, do the intratracheal isolation into the mice directly. It's a standard approach is to do like pharmacology testing or toxicology testing. However, this kind of approaches cannot really use for long-term exposure because asthma and COPD are this kind of like chronic pulmonary disease. So if we're using the intratracheal insulation, that'll be induce like a man-made damages by ourselves. So we try to figure out is there any approaches that we can use. So we are building a real-world exposure system, and we introduce the unconcentrated, just ambient air into our system. And at the beginning, we use a particle classifier. So we remove most of like a larger particle. So only PM2.5 can really introduce to our system. And there are two groups. One is with the HEPA filter. So that means we remove most of particulate matter. So in that group, only gas pollutants are exposed to the mice. And then last group is we call it PM2.5 groups. That means the mice is exposed to like particulate matters and gas pollutant at the same time, compared with the control, the mice housed in like animal center. So this is the picture for the entire system. And at the same time, we measure the air pollution levels and to see how the pollution exposure during like 3 months or 6 months of time. And we look at the system in Taipei City, in the National Taiwan University campus, and nearby is a Jilong Road. So here is very busy street. So we can see a lot of traffic during like a peak hour or like a rush hour. At the same time, there's an air quality monitor station operated by the EPA station, operated by the EPA. So that means the mice is really exposed to traffic emission sources. So the mice exposed the air we breathed. So what happened after like 3 months of time, 6 months of time? So we conduct about 3 months period of time. Actually, we originally planned to do 6 months exposure. However, after 3 months exposure, COVID happened. So we have to terminate the study. So we get a result for 3 months only. And during the 3 months, there will be 3 periods of dust storm. It's mainly come from China. So we can do the source of apportionment to understanding where's the long range transport from And you can see it's from like different cities of China. Some pass by Korea, some are not. But the receptors is the Taipei. So the mice is supposed to like a long range transport air pollution as well. And at the same time, we collect the particle matter on the filter subject. And we use a filter subject to do different types of like chemical analysis, such as like metals and polyaromatic hydrocarbon, so which means called like PAHs, which is identified as a first class carcinogen. So we can see the daily variations over different types like metals and different types of pHs that enable us to understanding what the mice really exposed and what's the major chemical compound that could be causing like damage in the lung of mice. And we also do exposure, we also do like a lung deposition model. As I just mentioned, we use that for estimated particle deposition in COPD subjects as well. So after 3 months exposure, we can see most of particles are deposited in alveolar region, and the other portions are trachea and bronchial regions. So that means more than half of particles are able to deposit into like alveolar region, the distal lung, and to interact with alveolar epithelial cells. So let's move to the animal results. We can see after 3 months exposure, the lung function did decline by air pollution, especially by the particulate matters. And the lung function declines associated with the metals that the animal really exposed. We can see like magnesium and cuprous are really associated with the lung function decline in the mice. And the next one is try to reduce, because the 3R, reduce, reuse, refinement for the animal welfare. So we measured the lung structures by HRCT. So we can use HRCT to reconstruct the lung, and then we use a reconstruct lung imaging to measure the emphysema by different period of time. So the red color means like the emphysema occurred by different groups, and then this is reconstructions. We can see more and more like emphysema development in the distal lung of like the mice, and also being confirmed by histology observation. So emphysema means like the alveolar wall really being destroyed. So this is normal animal, the normal alveolar structure. And after PM 2.5 exposure, we can see that the structure has been destroyed. And we also see the air wall thickness being increased by air pollution exposure. So based on the results between the CT scan and histology observations, we can really understanding air pollution really did the emphysema development. And the next one is very surprisingly. So we want to do the confirmations on patients. So we collect the lung tissue from COPD subject who is exposed to higher air pollution area during one period of time. And in the picture here, we can see there's a lot of black color-like particle really deposit on, we call it AT2 cell, type 2 alveolar epithelial cells in here in COPD subjects. So that means the particle really being trapped in COPD lung, and which can be really be observed by the lung imaging, and which means like there are more and more particles really being kind of like being trapped in COPD subject. So let's move back to the animal. So we try to understanding what happened on the alveolar wall. So we using a surface marker. SPC is for the type 2 alveolar epithelial cell, and the T1 alpha is the surface marker for the type 1 alveolar epithelial cell. So after exposure, we can see significant decreases for the AT2 cells and AT1 cells by air pollution exposure. And then we using the RNA sequencing and the single cell RNA sequencing to see how's the effect and what's the potential mechanisms underlies by air pollutions on AT2 cells. So we observe it be associated like the oxidative stress, inflammations, and mitochondrial functions. These kind of things are very general. However, we found the hippo pathway will be really involved into like a lung AT2 cells in response to air pollutions. So what is the AT2 cell and what is the Hippo pathway? So AT2 cell, which I just mentioned, is a type 2 alveolar epithelial cell, which is a progenitor cell. So in the alveolar world, the AT2 cells, which is a very important one cells that can differentiate into AT1 to maintain the structures of like alveolar. And also it can proliferate to the new AT2 cells. So these kind of cells being if like a dysfunction, that means like no cells can really differentiate into AT1, so leading to like alveolar wall being destruction. And the Hippo pathway means like let two Hippo pathways signaling component, one's the YAP, one's the TAS. They need to be translocated into the nucleus to activate the function of the AT2 cell. Then the AT2 cell can really differentiate from the AT2 to AT1. So that means if the function being dysfunctioned, that means like the AT2 cells cannot really differentiate into AT1 cells. So based on results, we using a cellular model to see how the air pollution is really associated with like a regulation in AT2 in Hippo pathway by YAS and TAS, and we can see that expression is dynamic, which depends on the exposure period of time by different hours. We can see it's really being changed by particle matters in 24 hours, and the results is also being confirmed in animals. So we collect lung sections from the animal to see how's the AT2, AT1 cells and how's the expression by the YAP signaling pathway. So we can see the YAP is still being decreases by the PM2.5, which means like it's really destroyed the function, dysfunctioned the Hippo pathway, and leading to the YAP or TAS cannot really translocate into a nucleus and inactivate the function of AT2 differentiate into AT1. And after the dysfunction, then the cell will processing or programmed to cell death by ATN, P53, and P21 pathway. So this is the summary pictures that being done by Vincent, one of my students. And we found air pollution exposure is really associated with emphysema and that dysfunction like AT2 cells by regulating the Hippo pathway. So that'll be the final slide. So in conclusions, I would like to say air pollution is a very important public health issues. It's not only associated with asthma, but it's also associated with COPD. And why I'm doing COPD? Because asthma is treatable. So the patients can really be managed by medications. However, for COPD, it's untreatable. So for the clinicians, they only can manage the COPD patient, not get acute suspicion, because frequent acute suspicion that leading to a lung function decline. So that decrease the quality of life in COPD subject and also probably leading to like a patient death in the end because the lung function declined. And the air pollution is not only important issues, and it also being important in the non-smokers. So when clinicians, they try to understanding how's the risk factors that are really leading to like a disease progress or disease development. First things is try to asking the basic or like we call it patient history. So how's your like behavior looks like? Are you smoking, and are you cooking at home, and are you do like incense spending? Of course, there's not many people do the incense spending, and how the pollutants you really exposed to. These kind of factors really help us, the clinicians, to do the diagnosis, and we can provide more information to teach the patient how you can protect yourself. And the other one is in biological views, we can identify alveolar epithelial injury caused by like a Hippo pathway are very important, which could be also associated with like emphysema development. And in the end, there's urgent need for like a cleaner air policy, exposure reduction, and early intervention strategy try to mitigate like a growing respiratory health burden. So there are three things we need to do in terms of like a public health student. Because for my background, I graduated from like occupational health and safety in public health school. So I would say public health is very important. because it's preventive disease happened. So we need more effort to let like a public to understanding how we can protect ourselves. So the public awareness are very important, and we need more like efforts to pursue and push the government to do so. And the other one is exposure reduction is more like environmental engineering. So how we can reduce it. And it also associated with public health or the other expertise, because you can either teach or you can let your friends know that by burning this kind of behavior, smoking are not good for you. So try to do this kind of behavior changes and reduce the air pollution exposure. For example, if there is a wildfire or building fires, were you close to see the fires or not? Normally, people will. So we'll go closer to see the fires. However, if you have awareness, you will note if you're close to the fires, you probably exposed to higher pollutants. Of course, it depends on the wind directions. So you are in the like a downwind or like a upwind, it's different levels of exposure. And then the other one is early intervention strategies. So how we can do the early intervention strategies by clinics. So either if a patient coming, we can give them more evidence or more like educations, how you can prevent yourself. It's not for the medication, not for the diagnosis. It's reduce the risk of severities in patients in the future. So that's on my side. I would like to say thank you, Dr. Farah and Dr. Vincent as well. And thanks all my research group and the funding resource. And thank everyone. I'm happy to be here.
Thank you, Prof. Chuang, for your very interesting talks and very excellent. And this is the big concern of all of us, yeah, in the world and especially in Indonesia regarding the air pollutions. Okay, we open for discussions. If there are, and yeah, okay, one and then second, three. Okay.
Good afternoon, Professor. My name is Hamza Abu Layel, PhD student, UGM, Department of Physiology. Thank you for interesting topic and interesting presentation. Just I want to say something about the COPD. We know this is a progressive disease and irreversible damage for the lung, and sometimes we need to find solution before we reach the COPD, because there are some disease we can treat with it, but when we say COPD, I think the damage, it will be irreversible. So when we talking about the air pollution, we talk about a direct a relationship with the number of the people. For example, in Indonesia, there are more than 200 million people live here, and sometimes you cannot change the air pollution. So sometimes we need to find the solution. The solution, like we using or wearing mask. Is it this is the one of the solution, or in my previous research says that exercise play important role to prevent COPD and many disease, because we know when you try to start in the exercise regularly, this means more efficient in the inhalation and exhalation. So I want your advice, which the best way to protect us from the air pollution, because sometimes you cannot change the pollution in Indonesia or in another region. Thank you so much, Prof.
Yes, very good questions, to be honest. So how we can protect ourselves? Of course, wearing mask is one strategy. But I would like to say it's for yourself. So how we can change everyone. So I think that will be much more important. So I've been to Indonesia several times, and thanks for Dr. Farah's invitation. And every time if we go to certain areas, we can see it's open firing, burning like a trash or rubbish. And it seems like they think this is kind of like a biomass because they're doing cooking at the same time. For me, it's really surprised to me. But the two levels of things. So how we can improve or we can change their behavior. I think it's really difficult. It's really being limited by like your like a family income, of course. So the first thing is try to let everyone understanding exposure to air pollution is really important. And it's not only associated with like a respiratory system, it's also associated like a disease. Because based on our study, we identify air pollution exposure is also associated with like a neurodegenerative disease as well, such as like neurosensitive like a CNS toxicity or Parkinson's and so on. And it also associated like a memory deficiency. So first things I would like to say is protect yourself and try to change the behavior from your family first. That's the first things that we can do. And for being a teacher, I talking about the air pollution, how important it is, and how we can change ourselves. So I would like to say for the young generations, it's still on time. Not today, you still can do that, change by yourself, and you can change the behavior for your college at the same time. I think if everyone do something, that'll be improved a lot. That's the first things. And then second is the exercise. Now that's very interesting because in Taiwan, we often take a walk about 7 to 8 o'clock. I know it's very late, but the people really want to do some exercise. So the rest time we can do exercise is at night. So we don't normally do exercise around like 8 or 9 o'clock because it's very hot in Taiwan, Taipei. However, for the scientific view, because Taipei is an urban area, so a lot of traffic emission sources. So for me, I try to avoid any pollutions being emitted into the atmosphere. So if you do like exercise at night, at around 9 to 10 o'clock, it's fine because the PM 2.5 level is decreased. However, the gas pollutants is increased. So it's really difficult. You cannot really choose which time will be better for doing the exercise. So I choose the other option. I work out in the gym. So that's the other option. And the other one is, I would like to say is, when I do the exercises outdoor, are you doing like a nose breathing or mouth breathing? Yeah, that's different. If we do a mouth breathing, that increase about 20% of particle really being increased, inhaled into a lung. Because our extrapulmonary system, the nasal health system, is really important to remove the particle. About 60% of the particle can really be removed, especially for large particle, by our nasal system because anatomy. Yeah, so most of particle, large particle can be removed. However, if we do like exercise juggling, use the mouth, that means most of particle, I mean the large one, are being held into our lung directly. So that causing more dangers to our lung system is a very important things that we need to notice. So I would like to say is when you do the exercises, of course, you can choose an indoor. There are lots of indoor exercise you can do. Or you want to do the outdoor exercise, you probably need to choose better time and a good environment. And I would not recommend the wear the mask for juggling because you probably will causing like hypoxia in the end. Okay, thank you.
Okay, thank you. Then second, yeah.
Thank you very much. Good morning, everyone. Thank you, Professor, for coming up with such fresh perspectives on pollution-related diseases. And I really appreciate how you reframed the challenges around this topic. But my question is not about this topic, since so far I know this is the last day for the series of lectures. Tomorrow we are going for a field visit. So I think I may not get the chance to ask this question. My question is about the effectiveness of One Health approach. I'm from Bangladesh. I'm talking from Bangladesh perspective. So far, I understand public health, especially One Health, the three components, human, animal, and environment, belongs to three separate departments. Human health belongs to health department, animal belongs to livestock, and environment belongs to forestry and environment in Bangladesh. So my question is, to what extent do you believe in a low-income country like Bangladesh, public health, One Health approach is effective, where bureaucratic hurdle is almost impossible to overcome? Thank you very much.
Yeah, it's a very good question, to be honest. So I would say it's a different discipline have a different expertise. And One Health is a very wide spectrum. Actually, it's cover almost everything. Now, medicines, biology, engineering, environmental sciences, and social science. It's almost everything. So different discipline have different aspect and different approaches to dealing with public health issues. But I would like to take me for example. My background, as I just mentioned, is public health, and then I did my PhD in inhalation toxicology and focusing on lung repairing, pathophysiology and repairing. So I jumped a little bit from like a data analysis to toxicology. And in the end, now I'm working in the medical school. So I would like to say is the first thing is probably you need to think about how you can expand yourself. So not just focus on the expertise that you are really studying. So because now the AI is coming, everything has changed too fast, to be honest. And before the COVID, I don't think AI is very important to me. That would be really affected my job because I have no concern about the AI before the COVID. But after the COVID, it seems like everything been changed, right? Too fast, to be honest. And even me, I done epidemiology work and do the traditional statistical analysis. But nowadays, I show the images about lung imaging reconstruction and the analysis done by AI. So that means I really involved in the AI already. So what I'm going to say is One Health is try to unique everyone together and try to solve out the health issues. And for the one, I think the one is for I would like to say for the narrow view, probably the one means like entire countries because different countries have different problems. So how we can unite together and try to get more resources or like public awarenesses to dealing with the issues that we are really facing to. That's the first things. In Taiwan, we are really facing to different issues. Of course, air pollution and water shortage. There are a lot of things we are facing too. But Indonesia, I think probably Dr. Farah have more idea than me because I just do short-term visit. But as far as I know, I would like to say as in developing countries, or I know not enough resources, what we can do. That's really the main things. I would say is you probably can do something, try to let people understanding or become the teachers in the future. You can let your student really understanding how important it is. And but I would say in these stages is get the knowledge that you have and try to do like a public awareness to everyone. And of course, do something.
Thank you.
Okay, thank you. Yeah,
Hi,
good.
my name is Mudassir Asim. I'm from Pakistan, a PhD student in MECOM University, Jogja. So my question is that during your recapitulations, you passed a remarks on that asthma is treatable or bypass. So how do you support your comment on it? Though asthma is one of the, I guess, is serious health issues. So how do you explain or support your idea or your comment on it? Thank you.
Yeah, that's a good point. So I can say is why I do the COPD and asthma is important, right? Can I say so? Is that the questions you ask?
How do you support your comment?
Yeah. So I would like to say that originally, because asthma and COPD are the common chronic pulmonary disease throughout the world, and there's still a lot of medications that try to identifying and try to treating the patient for asthma. And why I choose the COPD? That's the first thing I would like to say, because first of all, it's untreatable. So for me, I want to, from the public health of view, try to identify the risk. So for me, identify the risk. So it's much more important for epidemiology evidence we identify. So we can see children, elderly, existing disease patients, their population risk in terms of air pollution in COPD. So what I say is identify risk is important. And the next one is we get association, how we prove our hypothesis or prove the concept. So we're using different approaches. So for my student, first of all, is we try to make the hypothesis based on the meta-analysis. So we try to understanding, is that work being done already? So is this really work that we can do by meta-analysis that give us more evidence? Is that real or unreal? Is that something that haven't done already? So we use a meta-analysis to generate hypothesis. Then we go back to the epidemiology again for the data analysis to prove the hypothesis that we rest in our mind. Then we find some associations already based on data analysis. So next one is by using animal first. Actually, some people using a cell first, but we're using animal because animal results are more relevant to the human because of different barriers of a system we use to prove a concept. So we're using the animal build out different type of disease model. So today's talk I mentioned about is the one example for the disease model that we have. And we're also using different type of genetic knockout mice to prove the different genes that will be associated with the disease. So using a model to prove concept, then using a serial model to prove a molecular pathway. So it's a strategy that we are using. And I would like to say more and how we can really translate the results we identify from the population risk. Intermittent is an animal and to the medicine. So we identify certain type of biomarkers in COPD who is highly associated with air pollution. So we collect these kind of the proteins, analyze it by proteomics, and then we confirm it in patient again, and then go back to animal to prove a concept. So we identify the ITH4 protein, which cooperate with Dr. Farah as well. So we're using the ITH4 knockout mice. So we house the mice for almost an year to see is that spontaneous development COPD by emphysema in the knockout mice. And interesting, we found the gene knockout is really associated with COPD emphysema development. And we do one more air pollution charge to see is that really increase the severity or leading to acute suspicion or not. So it's all the model we build out. So we found the ITH4 is important. Then how we can do treating. So now we are doing the drug development. So we build out a ITH4 molecular drug. And for me, now we are doing the drug formulation because for the lung inhalations, by inhalations is much more important than IV injections or taking the pill. So we developed ITH4 inhaled powder drug, and then now it's finish the preclinical study, and we are almost going to the phase 1 study already. So what we can say is public health is important. And if we can go further to connect with medicines, then we probably can get more, and we can probably treating the patients in the future. Thank you.
Okay, thank you, Prof, for your answer. Okay, Jessica, yes, maybe. Is there any?
I have question.
Oh, sorry. Oh yeah, you can first. But yes, yeah, you can raise question. It's okay. It's okay.
Good
You're
morning,
first.
Professor. So thank you so much for such a insightful session. So my name is Mohammad Arif, and I'm from Pakistan also, and I'm a student of public policy and government. So my issue. My question is more about the societal issue that I have saw when I am in Indonesia. When a bad habit becomes a culture. So what do you suggest about it? Because in Indonesia, every person, not all, but most of them smoking, right? And this is a really big issue. And I have done a project on that the government also increases the price of the smoke cigarettes, but then because of the so porous borders, so a lot of smuggling smoke cigarettes also come inside the Indonesia. That's the same issue also. So what do you suggest about that? That when a bad habit becomes a culture, so how to get rid of it? Is there any safe smoking solution or some filtering or something like that? Because it's very hard. And even though if you ban it, people even smoke in a smuggling way. Yeah. Thank you so much.
Yeah. Indeed, I noticed that smoking is really big issues in certain countries, such like Indonesia. So it's smoking a lot, and the same as China. I was in China last year, and I was trying to check in the hotel, and there's one guy who's smoking in the lobby. Really surprised to me, just indoor smoking nearby me. So how we really facing the smoking? I would like to say is, of course, if you can quit, if the people can really quit the smoke, that would be much important. However, I don't think it's easy to do so. So I will not say any policies that we can do. Of course, we need to change the mind and probably using different kind of approaches to reduce the smoking. So I will take Taiwan for example. The government want to control the smoking behaviors. So first thing is reduce the secondhand smoke. For me, I'm not smoker. I'm really annoying by the smokers because it's smelling very bad. So first of all, I'll try to avoid the secondhand smoke. So the government using the restricted area. So this area is only for the smoker. So you want to smoke, only there can smoke, and otherwise you'll get fined. And there's no smoking at home, even in the backyard. Okay, so there's some people think I'm at home, it's my house, so I can smoke everywhere. So if you really smoke at home, you are not already affected yourself only, also affect your family and your children. So think about everything about your family. I think that'll be very important. So there are few things that we can organize this. I'm not sure, but I noticed that in the airport, of course, probably in the airport, there's areas for smoking. But for the public areas, it seems like smoking everywhere. So I know it's still a long way to go, but probably we can have like certain area that the smoker can really smoke. But for a non-smoker can really avoid the secondhand smoke. So that's the first thing I would say for the non-smoker. And then for the smokers, we are doing the cigarette smoke study now, and to compare with the heat tobacco product. And we are not doing the e-cigarette because it's too dangerous, and we are not sure what has been the major component inside. So different components have different health effect. But now we do the comparison between the traditional cigarette smoke and the heat tobacco product. We found that different burning approaches could really have different health impact. But I would like to say it's a good behavior. I would like to say is try to quit the smoke. Yeah.
Okay. Is it?
Can I comment on it? The government is giving awareness on to stop like smoking. Smoking is injurious to health. They are giving advertisement each and everything. But on the same time, the government is providing the smoking area. Why? I mean, don't you think it's
Government also seller of the is what
That's
seller.
wrong, because in Taiwan, everyone talking about human right, right? What's your right? So the government cannot really prohibit to ban the smoking, right? So let the smoker have an area that can really smoke. So that's their freedom. But for a non-smoker, we have our right as well. So we don't want to expose to secondhand smoke. So the government want to do some separation. The areas is for the smoking only, but most of the areas are free smoke. So that's the first thing. And I know you say it's kind of controversial, but in Taiwan, there's some policy like using. One is put a lot of like non-cancerous picture on the box of a cigarette smoke and on a cigarette, and banned it advertised on like a TV or anything, and they increasing the price. Yeah, the price is very higher in Taiwan for smoking.
Yeah, even like let's suppose I'm smoking. So if I take one cigarette, it's like nothing like that. Let's suppose if I go to the smoking area, it's already covered with smoke, and it will directly affect more than one cigarette.
And the consequences of smokers. Okay, maybe we give one chance to the in-person participants, and after they move to the Zoom participants.
Okay, first of all, thank you for the opportunity, Prof. My name is Jessica and I'm from Yogyakarta, Indonesia. I want to ask, from a One Health perspective, which intervention should be prioritized first to reduce COPD in non-smokers, like improving air quality or strengthening tobacco control or like reducing occupational exposure? Thank you.
Okay, so in terms of like One Health, I would like to say is like environment is much more important because yesterday I talking about climate change. So air pollution is also being affected by temperature, humidity under climate change. But climate change will be the other issues. I'm not talking about it today. But in terms of like One Health perspective, how we really change it or to improve our abilities, I would like to say is adoption. So how we really adapt the environment, like the Professor Daniel, he mentioned about we can use a filtration and so on. But I think it's for our self-protections. So how we really adapt the different steps. So from like public health, of course, we can like teaching the people for educations, or we can prevent the disease happen. But for the biology, for the pharmacology and so on, we'll try to understanding what's the mechanisms, identify any drug or pathways that are really involved in the disease development. And for the medicines, of course, treating patient, and probably the patient will facing more challenged by the disease severity under the air pollution exposure or under climate change, because based on our report, we found the air pollution has increased treatment time. That means a patient being acute suspicion in hospital, they need more time to be discharged and the difficult treating by infections as well. So that's different aspect. But for One Health, I would like to say is it's try to increase our adoption and awareness and be prepared.
Okay, thank you.
Thank you.
Okay, thank you. We now moving to from Zoom from Joseph Dargantes from Philippines. Yeah. Thank you, Professor, for the very informative lecture. Is there a global regulatory body that oversees and monitors air pollution worldwide, particularly with respect to compliance with 2021 WHO Global Air Quality Guidelines? Yes. Say hi for in Philippines.
Yeah, and I think it's very good questions. And then after the WHO, they set up the new guideline. And the guideline, I would say, is too low in terms of like PM 2.5 or different types of air pollutants levels. Even Europe or US cannot really reach to the guideline. So based on like epidemiological evidence, they say that if lower like a 5 microgram per cubic meters for PM 2.5 in a day's exposure. However, the 5 micrograms, you can think about it. It's very hard to imagine how low it would be. Like I would like to say for this environment, probably around the 10-ish microgram per cubic meters, and outdoor probably even higher. So now more and more like a medical society, they try to pursue the WHO to reduce or to change their air quality guideline step by step, not to the end directly. We need to more realistic. If we do like something that really can down to 5 microgram in Indonesia, generally outdoor would be 40 to 50 microgram. So you need to 10 times harder to reduce it. but it's for general. It's not really including like traffic emissions and so on, or or like indoor air pollution. So even in Taiwan, the average would be 15 to 20. So it's really difficult. So I would like to say is if we want to look at the WHO guideline, the medical society try to change the policy, and we need to do that step by step. Thank you.
Okay, thank you, because unfortunately the time is limited. So give applause to Professor Chuang. Yes, this is very interesting questions. Also, recently, if we talked about exercising outside, outdoor, the marathon, yeah, Prof, it's become more popular. So I also wondering how about this when there are so many people a marathon, yeah, in the regularly, and then they export from air pollution. It's it's also my concerns. And then you also mentioned about the public awareness, and then our in education for wearing mask. Yeah, wearing mask in Indonesia also need more effort to educate. Also my my concerns also. Okay, thank you very much. If you want to ask, yeah, to discuss about the air pollutions, and then want to more get information from Prof. Chuang, you can send an email to Prof. Chuang. And if you want to get a contact, maybe you can also ask the committee of summer course. Thank you very much once again. And there is one, yes, a little souvenir. Yes. Thank you for sharing. Yes.